femoral attachment goes, we just see a wavy contour of the ligaments arising from the tibia, but then it's a very horizontal appearance, and you don't see any femoral attachment at all. It's just taken up by fluid, which is present at site of the normal ligament attachments. The tibial avulsion of the ACL is relatively less common, and you can see that in young patients. If it happens, usually there is a piece of bone which comes off with the ligament, and for that reason, it's actually got a good prognosis, and following surgery, they can be repaired quite effectively. In the older days, when children were more used to playing outdoors on bicycles and running around and climbing the trees, a rule of thumb was that if a child presents with an acute injury and a swollen knee, they've got an avulsed ACL from the tibia. These days, obviously, we don't see it that often. You can get partial interstitial tears of the ACL, in which case you will get to see some increased signal intensity and some intact fibers, but most of the ligament is just turned into a myxomatous mush. Sometimes it's difficult to be certain if the ACL is torn or not. And when that happens, we have to rely on secondary signs of anterior cruciate ligament tears. And these signs are that you get to see anterior translation of tibia as compared to femur. I'll show you how you calculate that. You get to see an uncovering of the posterior 1/3 of lateral meniscus. The posterior cruciate ligament can be buckled. There is a characteristic bone bruising pattern present. You've got injury of the medial collateral ligament, and you've got a deep and empty lateral femoral notch. So anterior translation of tibia, because normally ACL is preventing exactly that from tibia to go forwards, particularly coming downstairs. And when there's no competent ACL holding the tibia in its place, it tends to slip forwards. So if you compare, on the lateral side, you have to draw a line from the back end of the tibia and draw a line from the back end of the lateral femoral condyle. And the distance, if it's more than, some people say 7 millimeters, some people say 5 millimeters. I tend to rely more on 7 millimeters rule. I call that as anterior tibial draw present. Have a look at the lateral meniscus posterior horn, and that has got a little bit of an uncovered area. Normally, this should be present sort of more anteriorly, and this is sort of flipped back a little bit, and that's, again, an indirect sign of ACL injury. You get a buckled PCL. So normally PCL has got a shape like that, but when it becomes buckled like this, then that's a sign. What they say is that if you draw a line from the back end of the PCL and it should cross the femur, this one's still crossing it, but I've seen it getting really straight, and then it goes like that, and in which case the line drawn at the back of the PCL will just go parallel to the posterior margin of the femur. So that's what buckling of PCL means. One of the commonest reasons why you get injury of the ACL is the so-called pivot shift mechanism. So in pivot shift mechanism, what happens is that you've got a slightly internally rotated hip, then you have a bent knee with the foot firm on the ground, and you've got internal rotation of femur and external rotation of tibia. And because of this combined movements, the ACL gets into an area of stress and it ruptures. And once it ruptures, you get injury first present on the lateral side of the tibiofemoral joint surfaces, and then it rebounds, and then you get bone bruising on the medial side. So it's this combination of characteristic bone bruising present on the lateral and medial sides, which results in the typical pivot shift injury. And this is what we see on MR. Because in this case, what happens is that you've got your foot firm on the ground and injury coming from the lateral side, you can imagine that the knee would be bent towards this side. And once it bends towards this side with additional rotation, ACL is ruptured. These two will bounce together, and then that would result in injury of the MCL because of the increased angulation present coming from this side and this side. This ruptures. you've got bone bruising here, and then once the force is released, then you get counter-coup injury on the medial side. So that's a classic pivot shift injury. And you see this characteristic bone bruising on the lateral side, and you saw the ACL injury here with a knee joint effusion, of course. So you get injury to the ACL, you got injury of the medial collateral ligament, you can get lateral collateral ligament tears and the characteristic edema on the lateral and on the medial sides. ACL injury again, and the characteristic bone bruising present here. So this again is an exam case, and when you see that, please make sure that you don't miss any of the important associations. I think most of you should be able to pick up the ACL injury, but look for the subtle sprains of the medial collateral ligament and the characteristic bone bruising pattern. All of those findings would need to be mentioned to get the maximum points. When the ACL ruptures, you get to see tears of the medial meniscus in a significant number of patients. Look carefully at the meniscocapsular area because that's the segment which gets missed. Look carefully at the posterior horn, look at the lateral compartment contusions, and look at the medial tibial contusions, which do happen, the counter-coup injuries, but relatively less common. ACL tears should not be confused with ganglion cysts within the ACL, which you can get to see in even younger patients. This finding has been described as a celery stick ACL. So it looks a bit like a celery stick, and we can see in the fat suppressed sequences, it's looking like that. A ganglion is essentially myxomatous degeneration of connective tissue. It may or may not be present in the joint. In this case, obviously, it's within the joint, the knee joint. The mucoid degeneration is a slightly related thing. You can call this as a celery stick as well. It's just a swollen appearance of the ACL with mucoid, bright signal intensity with low signal fibers running through. That's not a tear. The ACL, once it gets repaired, they may show you an example of a badly placed graft. In a nutshell, the graft has to be parallel to the Blumensaatz line. This is the line of the intercondylar notch, so it should be parallel to this line. If it's straight, then it will not be doing its job properly because it will be incompetent. Remember, the job of ACL is to prevent anterior translation of tibia. So if it is straight, then it's not able to do that. If it's more going like that, then it'll get impinged by the intercondylar notch. And again, it will result in an earlier tear. So it should be parallel to this line. The entrance of the femoral tunnel at the back should be about 3 to 4 millimeters in front of the posterior cortex of the femur. So two things. One, should be parallel to this line, and B, the femoral cortical appearance is just around here. If the graft tunnel is too far forwards, then the roof impingement happens. If it's too far back, then instability can happen. So normally it should be like this, but if it's too far to the front, it's getting impinged here and it will get rupture early on. If it's too far straight, then it will not be able to do its job properly and the graft reconstruction would be incompetent. You can get another important complication, and this again has been asked about in the exam, which is the presence of excessive fibrosis in the anterior intercondylar notch. This is the so-called cyclops lesion. And this is essentially a hypertrophic scar tissue which is present to the front of the intercondylar notch. And this has been likened to the dreaded cyclops. Please make sure that you've seen a few more examples of this because this is again an exam case. PCL injuries are less important as compared to ACL, But like the ACL, you can get avulsion from the femoral attachment, mid-substance, or tibial attachment. Usually happens with a dashboard injury in which the tibia is pushed backwards, which results in a bone bruising here, tibia goes back, and you get rupture of the PCL. Mid-substance or tibial avulsion. So combination, again, bone bruising present at the anterior aspect, bone bruising present here, and you've got rupture of the PCL at the back. Here again, we can see a big swollen PCL on this side, and you've got swollen PCL here with an injury present towards the femoral side. Combination of findings here. We've got no PCL, so there's a tear here, big cystic lesions present there, and you've got a tear of the lateral meniscus. So that's, again, an exam thing that they tend to show multiple findings. PCL tear from the femoral attachment and PCL tear from the tibial attachment, lower half. Avulsion from the tibia, we can see it coming off the bone. And in the coronal plane, we get swelling present here, along with a sprain of the medial collateral ligament. The avulsion of the PCL can sometimes be seen on CT scan when you've got a bone fragment attached. So we go back to the plain X-ray, you can just about see it there. In the AP view, you can see a little radiolucent rim around the avulsed fragment, but then we can see it quite nicely on the CT scan where the avulsion has happened. We can see the outline of the PCL with an avulsed bone fragment. On MR, of course, you will get to see bone bruising present posteriorly with a cleft separating the torn tear from the posterior margin of the tibia. And in the axial image, just see the bone bruising present. I'm going to take a 5 minutes break. collateral ligaments. Remember, the same theme. It's a two of everything. So we've got two menisci, we've got the two cruciate ligaments. Now we come to the two collateral ligaments. We've got the medial collateral ligament, which has got a femoral attachment, it has got a tibial attachment, and it is quite closely linked with the body of medial meniscus at the peripheral side. The lateral collateral ligament, on the other hand, has got more of a fibrofatty tissue separating the peripheral margins of the lateral meniscus and the lateral collateral ligament. Remember, in this space, we've also got the popliteus tendon on the lateral side. One important point to remember is that the tibial attachment of the medial collateral ligament is almost a hand's breadth below the upper tibial articular surface. So quite a few MR radiographers, if they've not been told, they will cut off the lower attachment of the MCL. So when you're training them, make sure that they know that they have to go quite a low way down. Otherwise, you may miss an inferior abnormality of the medial collateral ligament attachment to the upper tibia. Practical point. In the scrolling images, we will see that the lateral collateral ligament proper is attached further posteriorly, because remember, it has to be attached to the head of fibula. Medial collateral ligament, by comparison, is present more anteriorly. So going further back, there we are. So lateral side is just about beginning to be shown, whereas the medial collateral ligament has already finished. Now we can see a bit of the lateral collateral ligament coming up to the fibula. One of the signs, incidentally, of anterior cruciate ligament tear is that because of the ACL rupture, the tibia tends to rotate onto femur. And therefore, you may be in a situation in which you will be able to see the lateral collateral ligament in one coronal slice. Instead of the normal front to back attachment, which is seen in serial coronal images, if you see it in one sequence, the whole of it, then that means that there is a problem with the ACL, an important secondary ACL rupture sign. Here we can see it completely getting attached. So the LCL, the lateral collateral ligament, is seen on a series of slices, whereas MCL can be seen usually in the front one or two images only. Generally, a sprain of the collateral ligaments is classified like you would classify any sprain of any ligament. A grade 1 injury is when you get to have edema on one side of the ligament. So here we've got soft tissue swelling and edema present on the superficial aspects. That's a grade 1. This is actually slightly more because there's, I think, more fluid present on the deep side also. A grade 2 is once you get a significant degree of soft tissue swelling, which is present on both superficial and deep aspects. And a partial grade tear. And a grade 3 injury is when you have a complete full thickness rupture with a lot of soft tissue swelling and some bone bruising in addition to the soft tissue injury. Because it's a significant trauma which results in injury to the collateral ligaments, you can get to have multiple structures affected. So you will have injury to the medial collateral ligament, you'll have injury to the lateral collateral ligament, you have bone bruising present on the medial femoral condyle in the lower femur, and you've got soft tissue injury present at the peripheral margins of the lateral side also. So multi-ligamentous injuries are quite common. What about the two joints? We've got the patellofemoral joint and we've got the tibiofemoral joint. What you would get to see in these is the presence of chondromalacia. So that is softening of the cartilage. Then partial cartilage loss. Then full thickness cartilage loss. Then you will have subchondral bone bruising. In the elderly age group, you will get to have subchondral geodes developing, and then you will have problems of alignment. So When it comes to the joint space itself and the problem of the hyaline cartilage, then you will get to see a series of these sequences in the knee joint MR. We'll start with the patellofemoral joint, and when it comes to tibiofemoral, essentially it is the same sort of findings that you can see there. So I'm going to mainly concentrate on the patellofemoral joint. This is the important extensor mechanism. You've got the quadriceps tendon, you've got patella, the biggest sesamoid bone in the body, you've got the ligamentum patelli, you've got Hoffer's fat pad, and you've got medial and lateral patellar supporting structures, including the retinaculi, the quadriceps tendon extensions, and the supporting soft tissues. Very important to be aware of the normal anatomical variants of the patella. They can be important pitfalls. Important to understand the anatomical basis of the pathology of patellofemoral joint in terms of patellar positioning and the trochlear morphology. And important to understand the importance of the quadriceps tendon, patellar tendons, and the anterior femoral and knee joint fat pads. So I'm going to briefly cover all of these areas. Perhaps one of the most important anatomical variants in the knee is the bipartite patella, because people can confuse that with a fracture. Almost always present on the supralateral margin, can be bilateral in most of the cases. You see it in quite a number of patients, up to 2%, and almost always it's asymptomatic. When you have a symptomatic bipartite patella in patients who have had a superimposed trauma or because of the presence of crystal deposition disease, then there is an impressive degree of bone bruising present around it. The fluid cleft, which separates the bipartite fragment from the rest of the bone, has got a more fluid component present within it. And the fragments can be displaced with associated knee joint effusions. So if you see these associated findings, then you can call them as a symptomatic bipartite patella, which I must say is less common. Another important normal anatomical variant is the dorsal defect of patella. This again is present in the supralateral side, the two important structures, the two important normal variants being present on the supralateral side of the patella. And in this case, what you get is a little bit of a dip of the subchondral bone. Notice the cartilage is normal. Remember, this is the hyaline cartilage. So what I told you earlier, unlike fibrocartilage, which is low signal on MR, hyaline cartilage is intermediate on non-fat suppressed and bright on fat suppressed sequences. So you got a dip in the bone, but the overlying cartilage is intact. So classical location, when it is present in the supralateral side, it means that this is a dorsal defect of patella. Cartilage is intact, may rarely be symptomatic, and in those cases you will get to see some bone bruising in the adjacent bone. The patellofemoral joint can be subject to mechanical pain because of the maltracking of patella. What does maltracking mean? Maltracking means that once the patient bends their knee, their patella tends to go laterally. Once it goes laterally, it can catch a bit of Hoffer's fat pad between patella and the lateral surface of the femur, the trochlear surface. And this results in the fat getting impinged and the patient resulting in an anterior knee pain. This happens more commonly in patients who have got a high riding patella, so-called patella alta, as compared to patella baja, which is a low-lying patella. In patients who have got a dysplastic trochlea, this happens more commonly. So what you're looking for is a dysplastic lateral trochlear facet in a patient with a high-riding patella, which will have edema of the lateral aspect of Hoffer's fat pad. That's the usual sort of troika of problems in these patients. How do you calculate the bipartite high riding or a low lying patella, you find yourselves a nice sagittal image. This was initially described in plain X-rays, in which the knee joint is partly flexed. However, people then started using the same measurement in the knee joint, MRs, in which the patient's knees are almost fully straight. But if you have them slightly flexed in your protocols, then that's helpful. You calculate the craniocaudal length of the patella, and then you calculate the length of the ligamentum patelli. This goes on top, this comes down, numerator is below here and denominator is on the upside, so you just flip them and you get the Insal-Salvati ratio, which is, in females, if it's more than 1.5, it's abnormal, it's high. In males, if it's more than 1.3, it's abnormal, it's high. In terms of patella baja, which is a low-lying patella, the values are about 0.8. So I would say that as a rule of thumb, remember 1.5. I don't tend to differentiate between men and women. I think 1.5, if you can remember that, that's good enough. And remember 0.8. So if it's below 0.8, it's low-lying. If it's more than 1.5, it's high-riding patella. How do you know if the trochlea is dysplastic or not? People have described various measurements and rules. I would suggest that try and visualize what the trochlea looks like. If it's a shallow trochlea, if the medial side is smaller, and if the patella is subluxed on the lateral side, call it dysplastic. Okay? In the sagittal imaging, if you look at the lateral femoral condyle, and if you see the anterior margin of the trochlea and the anterior margin of the femur getting into a little step, that's a good sign of dysplastic trochlea. So if it's more than 7 millimeters, that's significant. Ventral trochlear prominence, a step-like transition. And if the shallow trochlea is less than 3 millimeters depth, that's abnormal. So if you read the papers, you will get to see all sorts of funny measurements in which they're drawing 3 parallel lines and they're measuring this depth and that depth. But essentially, that's what you need to see. Step-like presence on the front of the trochlea, on the lateral side, and the presence of a shallow trochlear groove. That's good enough. The medial facet is smaller, so that's a dysplastic shallow trochlea. The patella can be subluxed laterally, so more than 6 millimeters on the outside. That's abnormal. And the trochlear inclination is more than 11 degrees. So you can see that it's quite a shallow angle here between these two sides. And sometimes the trochlea, instead of getting a normal concavity, it gets convex. So that's a really dysplastic trochlea. Bottom line is that the trochlea would be very shallow, maybe even convex, and the patella would have subluxed laterally, which is what a dysplastic trochlea would look like. Surgeons want to know what the trochlear tibial tuberosity distance is, and this is an important finding in terms of trying to surgically correct this. What you need to see is the deepest point of trochlea, so point here, and then the center of the tibial tuberosity. If the distance between these two is more than 20 millimeters, then that means that the patella is significantly on the trochlea on the medial side and tibial tuberosity furthermore laterally, and therefore the angle of the ligamentum patelli is going to be a bit like this, which means that the patella will struggle to stay in the middle. It will be pulled towards the lateral side. And that's what the TTTG means, and that's how it's calculated. In trying to assess the ligamentum patelli, remember that you can have a little bit of bright signal intensity at the attachment of ligamentum patelli to the inferior pole of patella. This is not necessarily abnormal. This is magic angle, and magic angle you get to see in patients who have got, in patients in whom you're assessing this in sequences which have got a low TE. So the proton densities and the T1 weighted sequences, you will get to see that. If you do a long TE sequence, like a T2 weighted image, then this should disappear. Patellofemoral joint chondropathy is relatively common and traditionally and historically is underreported on MR. And that's actually one of the usual complaints of the knee surgeons from us. Because once they put an arthroscope in, the first thing they see is the cartilage of patella. And they identify that the cartilage is soft, you can easily probe it, it's looking blue and horrible. And when they see the MR report, we've said that, well, we can't see anything wrong with the cartilage because we can see it's smooth. MR tends to undercall it. So remember that chondromalacia, when it comes to patellofemoral joint, you have to carefully look for it. I'll show you what you need to see in that. In patients with osteoarthritis, you'll get chondromalacia. In patients with acute trauma, you will get acute injuries to the cartilage and to the bone. We can get into a problem of lateral patellar dislocation, subluxation, and then relocation, and excessive lateral pressure syndrome, in which the patella is always being pulled towards the lateral side. So this is what you need to see in terms of chondromalacia. Here, you've got the medial patellar cartilage, which is slightly more bright. So that's softening of the cartilage. Then grade 3 injury is when you've got a partial thickness cartilage defect over here. A grade 4 injury is when you've got full thickness cartilage defect with a significant subchondral bone bruising. So softening, partial thickness, full thickness with then subchondral change. These are the 4 grades of chondromalacia. And you should try and see these in not just patellofemoral joint, but also in tibiofemoral joint, over the weight-bearing surface of the femur and the tibia. The patella can get fractures, it can get avulsion injuries from the attachment of the ligamentum patelli, it can get stress fractures. This is the sleeve avulsion fracture at the lower end. You can get acute fractures, you can get chondromalacia and subchondral bone marrow edema. You can get osteochondral injuries of the patellar cartilage in the young patients. Whatever problems of cartilage you can see on the patella, you can also see them on the trochlear surface. You can get to see chondromalacia, you can get to see bone bruising, subchondral signal abnormality, osteochondral defects, softening of the cartilage in younger patients. Patellar subluxation is sort of an extreme event which happens because of this constant struggle between the lateral and the medial stabilizers. The lateral stabilizers win, they pull the patella towards their side, but then the medial side also kicks in and then it claims its prize back. Pulls the patella towards the lateral side. The patella hits the front of the lateral trochlear surface. You get bone bruising, chondromalacia at the adjacent surfaces, striking surfaces. You've got complete subluxation with rupture and stretching of the medial supporting structures. And then the medial supporting structures win. You get bone bruising on the medial patellar facet and on the lateral margin of the femoral condyle. And then you got injury of the supporting structures on the medial side. And then it pulls it back. So you get subsequent relocation. What we tend to see in MR, because we are not seeing that sort of a nice moving image, so what we get to see are the effects of what had happened. So this side, this is the lateral side. That's the patella. We can see significant soft tissue injury on the medial side involving the medial patellar retinaculum and the MPFL structures and the vastus medius obliquus. And then you've got significant bone bruising on the lateral surface of the femoral condyle. The patella was actually gone here and then relocated. And you got significant bone bruising present on the lateral margin of the femoral condyle, low T1, bright T2. So that's the classical appearance of a patellar subluxation and subsequent relocation effects. Tends to happen more in patients with high riding patella and in patients with trochlear dysplasia, as I explained earlier. Here, the same sort of thing has happened. In this example, there is a significantly greater degree of edema of the medial side of patella and a relatively less prominent edema of the lateral femoral condyle. Also notice that in these patients, you've got significant sprain of the medial collateral ligament, lots of soft tissue swelling, injury to the medial patellofemoral ligament and the vastus medius obliquus muscles on the medial side. Women is patients who present with anterior knee pain. And these are the patients who have got an excessive lateral tilt of the patella, and they've got advanced chondromalacia of the lateral patellar surface, and they present with edema of the lateral aspect of Hoffer's fat pad. Coming to the patellar tendon, injuries to patellar tendon are relatively common. They can have an acute trauma resulting in a partial or a complete rupture. You can have chronic trauma resulting in tendinopathy. And then you can get infiltrative disorders in terms of gout, crystal deposition disease, and giant cell tumor of tendon sheaths. All these pathologies in patellar tendon can happen. In terms of trauma, I've seen this quite commonly in footballers, both in professional, semi-professional, and the amateur athletes. You get excessive edema and swelling of the inferior half of patella. Notice that this is significantly greater than the initial example of magic angle artifact that I showed you. This is significant trauma, lots of soft tissue associated swelling present. This example, it's got a complete full thickness rupture. Here you've got an extensive deep surface partial thickness distal half injury of the ligamentum patelli. In children, you can get avulsion of the tibial attachment of the ligamentum patelli. In patients with chronic injuries, you can get chronic tendinopathy in which there would be swelling present on the deep surface predominantly with bone bruising. Again, notice that this is significantly greater than the magic angle artifacts I showed you earlier. And in the axial plane also, you see this edema of the attachment of ligamentum patelli to the inferior patellar pole. On MR, you will get to see diffuse swelling of the ligamentum patelli. This is an extensive case of tendinopathy with a longitudinal split tear. We sometimes try to treat them with injections of platelet-rich plasma with variable success. In patients who've got limited problem, this is a distal one, that's a proximal one. So that's more like a chronic tendinopathy and delamination tear. You can get stress-related injuries like patients who are in the habit of jumping, like Sinding-Larsen-Johansson's disease. It's a chronic avulsion injury of the proximal tendon-bone junction. Has been described in patients with who play basketball, jumping athletes, and in paradrop soldiers and professionals who do parajumps. In young patients, we've all heard about the clinical syndrome of Osgood-Schlatter disease. It's type of an avulsion injury and osteochondritis of the tibial tuberosity. Remember, it's not the fragmented appearance of the tibial tuberosity apophysis, which is important. It is the associated soft tissue problems and bone bruising, which if you see, then you call it as Osgood-Schlatter disease. I tend to use the term that the appearance is in keeping with the clinical syndrome of Osgood-Schlatter's disease if I get to see soft tissue and bone bruising, not the fragmentation of bone. You've heard about the fat pad impingement earlier. This is what it looks like. So this patient has a high riding patella, and you've got on the fat suppressed sequence, this fat should be completely dark, but you've got bright signal intensity here and bright signal intensity on the lateral side of Hoffer's fat pad, along with some bone bruising present. I have not included tumors in this section because that would have meant a completely different and another long session by itself. But when it comes to synovial proliferating masses, remember, pigmented villonodular synovitis is by far the commonest diagnosis. You see 9 cases of PVNS, and then you see 1 case of synovial osteochondromatosis. Primary malignant tumors of the knee joint synovium are extremely rare. I've not seen any which primarily arise in the knee joint. I've seen tumors invading from outside, invading the joint. That happens rarely. But for practical purposes, if you see a predominantly knee joint synovial mass, it's either going to be PVNS or it's going to be synovial chondromatosis. PVNS is far more common. This is a more extreme example of Hoffer's fat pad edema. So high riding patella again, patellar maltracking, and you see bright signal intensity in the lateral aspect of Hoffer's fat pad with some adjacent bone marrow assignments. On the coronal imaging, that's the lateral side, and you see very impressive edema of the lateral aspect of Hoffer's fat pad. So in the extensor compartment, there are quite a few pathologies which can be seen. I've shown you examples of congenital malformations in terms of a high riding patella and a combination of high riding patella and trochlear dysplasia resulting in problems. I've shown you examples of acute trauma, acute tendinopathy. Then I've shown you examples of chronic trauma and chronic tendinopathy, stress-related injuries, both at the attachment of ligamentum patelli to the inferior pole of patella, the Sinding-Larsen-Johansson's disease, and the distal ligamentum patelli attachment to the tibia, the Osgood-Schlatter's disease. We briefly talked about tumors and soft tissue masses around the knee. Moving on to another typical exam case, which is hyperextension injuries. These occur in extended and locked knee. So patient has got their foot firmly fixed on the ground, and you've got a big force coming in from the front. There is an impaction anteriorly, similar to the dashboard injury I showed you earlier, which resulted in avulsion of the PCL. You've got marrow edema at the bone surfaces which have been struck. And then you get soft tissue injuries present on the opposite side, i.e. back of the knee. And you get posteromedial and posterolateral corner injuries. So that's a classical pattern of injuries. Flexion injuries, by contrast, are less extensive bone bruising. They result more in ligamentous ruptures. A shearing and rotation is there, which results in non-contiguous bone marrow edema, the counter-coup injuries, the pivot shift examples I showed you earlier, and rupture of the anterior cruciate ligament. Thankfully, because of the strong ligaments present around the knee, the dislocations of the knee are less common. But once they happen, they really have got a very bad prognosis because there is a significant degree of incidence of injury to the popliteal artery, which is running right behind the knee. Between the anterior and posterior dislocations, the anterior dislocation is more common, which means that the tibia has come further anteriorly. You get injury because of hyperextension mechanism, in which there would be rupture of the posterior knee joint capsule and of the PCL. So this is what you get to see on plain X-rays. In the lateral view, we can see that the tibia has gone forwards, and in the coronal plane AP film, there's a significant degree of lateral shift of the femur in relation to the tibia, or a medial shift of the tibia in relation to the femur. Of course, it's the lucky patients who get to this stage. The patient will present with a pulseless lower limb, no pulses being palpable, and then somebody has to quickly think what's going on. And if you get to see an angiogram, that's what you would see. significant injury of the popliteal artery with a very poor distal runoff. In terms of MR, just be prepared to see the most horrible looking knee you would ever see. It would take you a good 5-10 minutes just to identify the structures which you can and which you can't see. So in this case, complete rupture of the medial collateral ligament should be spotted first, significant bone bruising, extrusion of the body of medial meniscus, meniscocapsular injury, huge soft tissue hematoma present around the lateral side, soft tissue injury present between the iliotibial band and the lateral femoral condyle. I would be surprised if any ligaments in this patient are intact, and there we go, anterior cruciate ligaments ruptured, huge soft tissue injury present at the posterior margins. You can imagine that the knee joint capsule is definitely gone here. You've got traumatic effusion present within the knee joint. You've got extensive bone bruising. These are the exam cases that we know have been asked about in FRCR 2B. So be prepared. Don't get overawed. Stick to the rules that we've described. I've tried to describe in coverage of the knee. Stick to the two structure analogy that we've used. Look at the medial and the lateral. Look at the anterior and the posterior. Look at the quadriceps tendon and ligamentum patelli, and you'll get them all in the end. So notice how extensive the injury to the posterior knee capsule is here. You've got the injury present of the posteromedial and the posterolateral corners, extensive edema present to the front. ACL is ruptured, PCL is ruptured, collateral ligaments are torn, and the posterior capsule is ruptured. Notice how closely the popliteal artery is to all this significant soft tissue trauma. No wonder it gets affected in almost 50% of patients who are unfortunate to see these injuries. So in conclusion, we have gone through a whirlwind tour of knee joint MR. I've tried to encourage you to look systematically at structures, including the medial and the lateral menisci, the anterior and the posterior cruciate ligaments, the medial and lateral collateral ligaments, and the tibiofemoral and the patellofemoral joints. I know that your exam is imminent, but there is life beyond the FRCR 2B. Trust me, it starts after that. So you've got to build your database of what normal looks like. The more normals you see, the better you would become in picking up the abnormals. I'm going to stop here and give you a little rest and respite. And you've got the feedback form again, which you have to fill in, please. Thank you.
Just a recap quickly that these are all Viva questions, and that for local staging you will do an MR if there is a tumor, and one Viva question is that you will do at least one lesion in which the whole bone is covered. For example, if there is a tumor here in the distal end of femur, you have to do one sequence covering whole of the length of the femur till the hip joint. And the rationale is to pick up any skip lesions. So, in Stanmore, which is Royal National Orthopaedic Hospital, please remember in UK, we have got specialist bone tumor centers, and in London and in surrounding areas also around London, all cases are sent to RNOH. They do a single T1 weighted sequence covering that bone. For rest of the staging, you can do a CT chest, but if there is a liposarcoma, you can do also CT chest, abdomen, and pelvis. Whatever you say, it doesn't make a difference. Please remember things like osteosarcoma, which cause pneumothorax. You know that that has come in the exam. Nuclear scan you will do, but another thing is, just 1 second, let me disable the annotations. Right, so nuclear scan. In some centers, whole body MR, which include a T1 star, is now being used. And if there is Ewing sarcoma, there is a role of PET scanning. And in the Viva, you will always say that I will refer the case to a bone tumor center. Never say that I will do the biopsy myself. Okay, from the perspective of the exam, marrow is, for marrow imaging, the key sequences are T1 and STIR. Remember that, T1 and STIR. On T1, the fat will be, because of the fat content of the marrow, it will be high signal. And if you go to a PD weighted sequence, it is very difficult to differentiate between the marrow. But please remember that the soft tissue structures like ligaments, tendons, etc., they are better seen on PD weighted sequence. So that's how you can discriminate between the two. Usually, examiners will not show you a PD weighted sequence. They can show you a PD fat saturated sequence, which is a most widely used sequence in UK, because this sequence allows you to see everything like bone bruising and ligament, menisci, tendons, etc., just utilizing a single sequence. STIR sequence, which is very good to pick up bone marrow edema, better than PD weighted sequence, but you don't do it as a routine. On the other hand, if you are worried about infection or trauma, you would like to include it. Okay, candidate 1, rapid fire. What is your diagnosis?
Bilateral avascular necrosis of the femoral head.
Right. What is double line sign? Can you describe it on this case?
So double line sign is a sign that you see with AVN, and it's two-part process where you get granulation tissue and dead bone. And
so on which sequence, this is a Viva question, on which sequence you see the double line sign, and can you point it out to me?
Here on the T1 weighted sequence.
Can you move the mouse? I cannot see the mouse. Yeah. So can you go back, please? Yeah. So the point is that it is seen on T2 weighted sequence, and Double line sign is on T2 weighted sequence, and these two lines, one of the interface between normal and abnormal bone, and second is granulation tissue. So this is an exam case. This patient has presented with pain. What is your diagnosis? And what will you be worried about? What will you do?
So my diagnosis is an osteochondroma. I'll be worried about a malignant transformation. I'll correlate to see if the patient has previous imaging to see if this has grown, and I would also correlate the patient has pain, so I'd recommend an MR to measure the cartilage cap.
This is the one sequence of MR.
So on this axial sequence, I can see the same corresponding osteochondroma. So I would measure the cartilage cap, and if it's more than 15 millimeters, then that's at increased risk of sarcomatous transformation.
And this one actually is less than 1 centimeter. It is less than 10 millimeter.
So if it's less than 10 millimeters, I wouldn't be worried about malignant transformation.
Right. So please remember, osteochondromas have come in the exam, and osteochondromatosis and various syndromes, and there is a rate of malignant transformation. Pain is taken as a sign of malignant transformation. So pain is taken, but counter argument is that many a times, because of mechanical effect, patient will feel this pain. So you are absolutely right, comparison with previous film, but at times it might not be very helpful. You do an MR. On MR, you measure the cartilage cap. Less than 1, there is a black and white world, and there is a gray world. The black and white world, there is a bit of discrepancy in literature, but having said that, everybody agrees that less than 1 centimeter is benign. And more than 2, and some people think more than 2.5 is taken malignant. In between is the gray world. From your perspective of the exam, when you are in the gray world, if it is between 1 and 2, even then you will say that this is it. I will take a second opinion. I'll refer the case to a bone tumor center. Another osteochondroma, what is again increasing pain, what will you do?
So again, I would compare to any previous imaging and would recommend an MR to further characterize.
Here is the MR.
So on the MR, on the axial T1 weighted imaging, I can see the pedunculated structure. It has a very large cartilage cap associated with it. I can't measure it, but just looking at it, it does look larger than 1.5 to 2 centimeters. So I would be concerned about malignant transformation to chondrosarcoma in this patient, and would recommend referral to a specialist orthopedic unit. Okay, fine.
If you see, this is the bony part, and then this is the cartilage cap. You don't have to measure it. It is definitely more than 2.5. Cartilage on a T2 weighted sequence or a PD weighted sequence, it appears as high signal. And if there is some calcification, etc., that will be, which is the chondroid matrix, that will be low signal. So this is potentially malignant. Okay, let me now try to show you a case in a sort of a scrolling format. Let's see if it works. So candidate 1, can you see case 1 written in front of your eyes?
Yes, I can.
So I am going to give you the mouse control again, and let's see if Now, this case is a 19-year-old right lower limb swelling and tenderness. So there was a calf swelling there.
Okay, so got a frontal radiograph of the right tibia and fibula. I can't, having a look at the fibula, the mid shaft, there's an eccentric area where there is poor definition with some cortical irregularity. And I can also see an impression of a soft tissue component in the tibia and fibula, surrounding both the tibia and fibula on both sides. And I can also see foci of calcification, which would be unusual for a patient of this age. Given putting all these together, I'm concerned about a soft tissue process causing an extrinsic compression on the bones. And
right. So this is the lateral?
Yeah, and the lateral confirms this, where you can see a posterior increased soft tissue density with phleboliths.
Okay, so just 1 second. Let me recap for everybody. So what do you think, how will you describe the finding here?
So there's an ill-defined area involving the lateral cortex. It has a wide zone of transition. It's poorly defined, and I'm concerned that this represents an aggressive process. There isn't any associated involvement of the medullary cavity, and it's quite focal in nature.
Right. So what would you like to do to characterize this?
So I would recommend an MR.
Okay, so this MR, you can scroll through it. Let's see if it works. It's in a PowerPoint mode, but the images will come one after the others. And all of the audience, if you can just take your time, just scroll through it slowly and keep making up your mind what is happening. And if you want to describe it, there are 4 or 5 series which have been given to you.
Okay.
So on this series, can you describe your findings?
Yeah. So so we got posteriorly, there's multiple.
What is the sequence?
So this is a fat suppressed sequence. It's a stir.
It's a stir sequence. Please continue.
So in the posterior compartment, or in the calf aspect, there is an increased serpiginous structure, which appears quite tortuous. It appears to also be in continuation with the vessels.
What's happening to the fibula vis-a-vis the lesion? Go to
so the fibula, there's also mild edema, very mild edema of the fibula, and it appears to also have a local mass effect extrinsically, so an impression of an extrinsic compression on the fibula from these.
Please continue. There are more sequences for you to see. There will be axials also.
Okay. So once again, on the axial, I can see these serpiginous.
Can you stop here? Can you stop here?
Yeah.
Now, where is tibia? Where is fibula? And what sequence this is?
So this is an axial stir sequence, and the fibula is here. I don't know if you can see my mouse, but it's...
Yeah, we can.
And the tibia is here. So this posterior serpiginous structure, which is predominantly within the gastrocnemius muscle, appears to circumscribe around the fibula posteriorly, and is in close contact with the fibula, and appears to extend within the cortical aspect laterally which will be corresponding to the finding that we found on the X-ray.
Okay, just stop here, please. Anything comes to your mind? What is happening in this region?
The patient, the diagnosis. I think, given that it's serpiginous, there were what I thought were phleboliths and in continuation of the vessels. I think this may represent a vascular malformation.
Okay, please continue. Please continue. There are more sequences. What sequence is this? Can you stop here?
Yeah. So the marrow is quite bright on this sequence, and the muscle is of intermediate signal. So I think it's a T1 weighted sequence.
Correct. This is a T1. Please continue.
So
stop here, please. Yeah. Can you describe your findings?
So using the muscle as a reference point, there's intermediate signal involving the fibula, and external to the fibula within the soft tissue, I can see a slightly high subtle area within the local muscle. And
right. Please continue. So this one is with contrast.
Okay. One in this sequence, I can see enhancement within the muscle on this side here, and the gastric membrane muscle. There appears to be areas of increased enhancement, and once again, I can see bright enhancing signal within these areas, which will be more in keeping with a vascular malformation of the lower limb.
What do you mean vascular malformation? Which kind of vascular malformation?
Which kind of vascular malformation? I think it's a venous malformation.
Okay. How will you confirm this diagnosis?
So I think I'll have a look and see if I'll try and follow the vessels back and see if it connects to vessels or arteries. The patient will likely need further imaging, and
what kind of imaging?
So interventional radiology may have a role in this aspect. Doing a catheter angiogram may be helpful, and
okay, I'll take over, please. Right. Okay, well done. So the point is, this is an exam case, and the key thing here is that if you see there is an aggressive lesion here, and then we saw on MR that it had to be aggressive because whatever the lesion is, it was invading the bone. Key thing is these phleboliths. So this is what we call a intramuscular hemangioma. Of course, you are right. These days, the classification is different. And there is a concept of venous malformation, we know lymphatic. There's a bit of classification according to which component is dominant. Now, here, one take-home point for sequences in MR for the exam is that use the terminology of what we call fluid-sensitive sequence. So if you don't know it is a T2 or a PD fat-saturated, if you are very sure it's a star, it's fine. Otherwise, if you use the terminology, it's a fluid-sensitive sequence, you cannot be wrong. So what is happening is that this lesion, as we saw, it is invading the bone, it is transspatial, it is intramuscular. And here, if you look carefully, there are fluid levels. And this is that phlebolith, this is that phlebolith. And key Viva point is, how will you confirm it? And interestingly, you will confirm it with a Doppler. So what we do is, you just do a compressive study with Doppler, and it will just compress. Compressibility is what you are looking for. So, and on the plain film, if you do not pick up the phleboliths, then you will completely take it wrong and you will say that this is an aggressive lesion. Please remember that there is no role of, it's not an arteriovenous malformation. It's a venous malformation. Old name was intramuscular hemangioma. If you want to use that word, it's fine. So it will be connected to the veins and not the arteries. Right. So this is your second case now and your last case. So this is a 24-year-old diarrhea and weight loss with hip and back pain. Yes, please.
Okay. So frontal radiograph of pelvis in a 24-year-old patient, male patient. So the first thing that catches my eye is in the left proximal femoral shaft, there is an eccentric lesion.
I am not interested here. Don't worry about it. Please continue.
Sure. So I know the patient has back pain and diarrhea, so I'll start off with looking at the spine. Can't see any abnormality within the spine. There's reduced joint space within the sacroiliac. The sacroiliac joints bilaterally are not well appreciated and they appear to be fused. Having a look at the lower lumbar spine for any evidence of ankylosing spondylitis, I can't see calcification of the ligaments. Having a look at the femoral heads bilaterally, I can't see any evidence of avascular necrosis. There's no evidence of enthesopathy in the pubic symphysis or the pubic rami bilaterally. So given that the patient has diarrhea and bilateral sacroiliitis, my concern would be that the patient may have an inflammatory bowel disease such as Crohn's disease.
Okay, so we did an MR for the patient. Can you scroll through, give me your findings, please?
So starting with this sequence, this is a T2 weighted sequence in coronal plane of the pelvis. So focusing on the sacroiliac joints to begin with, I can see some areas of high signal involving both aspects of the sacroiliac joints bilaterally compared to the muscle. As seen on the radiograph, there's reduced joint space and complete narrowing of the sacroiliac joints. I'd also have a look at the rectum and anal region for any evidence of inflammatory bowel disease. I can't scroll anymore.
You cannot? Sure?
Yeah, now I can. I think.
Okay.
Yeah.
So go to the next sequence, please.
So this is a fluid sensitive sequence in coronal plane. And again, I can see bilateral signal change within the sacroiliac joints. It appears to affect the left sacroiliac joint more than the right iliac joint, and it appears to affect both the sacral aspect and the iliac aspect of the joints. There's also a impression of some irregularity to the sacroiliac joint space. Having a look here also at the anal region, I can see this abnormal high signal here. and it appears to, as I extend, it looks like it's extending. So there's a high signal, and it appears to extend at approximately 7 o'clock upwards.
There are more sequences also.
More sequences, okay, I'll carry on.
Yeah, there is an axial, and you might be able to orient it more. You know, this is, consider it a long case for you, right?
Sure, okay.
And the marks will be according to your findings.
Okay, so at 7 o'clock position in the rectum, I can see this high signal tubular structure, which appears to extend from the anal region. It has a central low signal focus within this area. Looking higher up, trying to see if it involves the anal sphincter, and doesn't appear to involve the anal sphincter. And I'm just having a look at this low signal focus within it.
Okay, that's fine. Please continue. Anything else in the bone?
Yeah, so having a look at the inferior pubic rami, I can see high signal anteriorly involving the pectineus muscles, more so on the right than the left, which would be in keeping with enthesopathy. And there's also abnormal high signal in the involving the right inferior pubic rami. So
roll through rest of the pelvis, go up.
An element of osteitis. Okay, I can see this. So there's also abnormal signal and some edema surrounding the sigmoid colon, and there's an area of.
Okay. So what is your conclusion?
So my conclusion, given that this is involving the anal region and the sacroiliac joints, this is likely to be enteropathic arthropathy, and it's most likely to present Crohn's because ulcerative colitis typically spares the anal region. So this would be my unifying diagnosis, and given these findings, I would recommend referral to rheumatology and gastroenterology, and the patient will need possibly an MR enterography to have a look at the terminal ileum and to assess for any active strictures.
Okay, excellent. I'll take over. So, as I told you, consider it a long case. Now, on this was the finding which was picked up. There was sacroiliitis bilaterally. And on this T1 weighted sequence, even here, you can see this loop of bowel to be thick-walled. And even on this coronal, you can see that there is a perianal fistula. Actually, this is a perianal fistula. It goes to 6 o'clock position. So the cutaneous opening was closer to 7. Otherwise, it was 6 o'clock. Now, this sequence, the T2 weighted sequence, is not a very sensitive sequence to pick up bone marrow edema, though, because the finding was quite emphatic, we could see something happening. Now, for seronegative arthropathy, the key sequences are T1 and STIR. So, once you know it, there is no harm in using this word STIR. Of course, you are not right and not wrong if you say it's fluid sensitive, but the point is that if you know it, for example, in head and neck, we know we always do a STIR sequence. Just call it a STIR sequence. So for seronegative arthropathy, we always use T1 and STIR. Now, you can see so many sites here. You know, enthesopathy, here, you know, these ischial tuberosities, and then this is that fistula, which is also on this coronal sequence. In the exam, they might not give you as many sequences as I have given you. They might just give you axial sequences, and time is an issue. So if I give you too many sequences, then it's not good for you, actually. So even here, you can see this bowel to be inward. So if you see, this is the sigmoid colon. Of course, it's very difficult to pinpoint what it is. Actually, it was the small bowel. It was not in continuity with the sigmoid. So here you can see it goes, and then at 7 o'clock it communicates here. Sorry, 6 o'clock. Right. Okay. Thank you very much, candidate 1. And now we go to candidate 2. Can you raise your hand, please?
Hello.
Okay. Thank you. So I am going to stop this share, and I am going to show you some rapid fire further cases before I give you 2 cases like in a Viva format. Okay, this one I don't want you to tackle it, but I will basically, okay, just tell me what is, because of time factor, I'm going to ask you leading questions. What do you think is happening here?
I can't see the screen.
Oh, sorry. So maybe it's not shared correctly. Can you see it now?
Yep, so I've got
Just tell
right
me what is happening here.
there's an impression of a lytic lesion with a peripheral area inferiorly of sclerosis. There's no aggressive periosteal reaction.
So if you see the AP view, do you think it is a lytic lesion or?
It's more of a kind of, I get the impression that there has been a lesion and that there's localization or something or going along that line.
MR of the same patient.
Fine. So there is an active lesion within the proximal tibia that is hypo-intense on T1, hyper-intense on STIR, and is central, but within the epiphysis. It's got quite cauliflower, and on the cauliflower appearance, and there was an impression of arcs and swells. So I think this is a chondroid lesion, and depending on the age of the patient, I think they were older. So a chondroid myxoid fibroma is a differential, or?
So is there, the patient has got knee pain. Do you think this lesion is aggressive? There is malignant transformation?
It's got a narrow zone of transition, and there's a paucity of any surrounding bone marrow edema, and there's no soft tissue component.
Right. Okay, let me take over.
Yep.
You see, enchondroma versus malignant transformation of enchondroma to a chondrosarcoma is an important exam case. So please remember the basics that enchondromas, or these days they are referred to, chondroid lesions. They just call it chondroid lesions. So meaning that there is cartilage, chondroid cartilage. Has got the chondroid cartilage we are talking about is this calcification or calcific matrix on a plain film. On an MR, it gives you this lobulated appearance on fluid sensitive or T2 weighted or PD weighted sequences. It's quite classical. The calcification within it might appear low signal. The malignant transformation of an enchondroma or chondroid lesion, whatever you want to call it, on a plain film has got some characteristics, as in, it will become lucent, so there will be a lytic lesion and other parameters. So first of all, pain is again just like osteochondroma, then comparison with old films, then it will become lytic, so there will be end osteal scalloping, and the scalloping will be more than 2/3 thickness of the cortex might be involved, and similarly in a craniocaudal dimension, more than 2/3 of the height of the lesion will be involved. And if you have got an MR, then there might be some cartilaginous loss. So these are the parameters which we have covered before. But the idea here was just to show you a benign lesion and chondroma without any stigmata of malignant transformation. Now with that, let me show you another case. What do you think? Increasing right arm and shoulder pain.
So I would compare with previous to see if there was any other lesion or if this was new.
Right. So because of time factor, what do you think is happening? How will you describe this calcification?
It's a pigeon. I get the impression that this could be a bone infarct or.
Why do you say that? You used the word serpiginous. Where is it? Can you confirm? Can you convince yourself?
I would more that it's more of a sign on MR, I think.
Right. So your initial answer was that let's go back, and you say that I want to compare it, right?
Yeah.
So we did not have a X-ray to compare, but on PACS there was a chest X-ray, and on chest X-ray the right humerus is visible here. So the lesion was there, right?
Yeah,
so
and stable in appearance.
Put it right and left. Anything comes to your mind?
Overall, broadly, it appears to be in the same distribution in length, but what I would be looking for is endosteal scalloping and increased lytic lesion, which there is increased lucency in the inferior aspect of the lesion. This, alongside pain, is concerning for malignant transformation, so would need to further evaluate with MRI.
Right. So the concept is that if there is malignant, it becomes differentiated. If it becomes malignant, it might eat up the calcification or the chondroid matrix. So there will be destruction and it might become more lytic or lucent. This particular case, I don't have good sequences. So just to make the point that this is the classical chondroid matrix we were talking about. And this is that lucency. If I give you axial here, only then you will see it very well. So here there is, one can raise the issue that there is malignant degeneration of chondrosarcoma, and chondroma. So please remember, malignant degeneration of osteochondroma, malignant degeneration of enchondroma, both of them are exam cases. For enchondroma, do not do a mistake, which many people do. Many people say that I will do a nuclear scan. And nuclear scan, the problem is that nuclear scan is absolutely non-specific. Enchondromas, I think about 30 to 35% of them, they might show uptake. So that is not a criteria. Don't use a nuclear scan. Okay. This is 23-year-old. What do you think is happening in this knee joint?
There's a large joint effusion.
And there is no history of trauma. What comes to your mind?
A hemarthrosis.
What will you do next?
An MRI.
So this is the MR. What sequences are these ones? What do you think?
I've got these are at the top. I've got PD FATSAT or T2 sagittals, and the first on the second row is T1, and then axial T2 FATSAT. So yeah, okay. And then
if you look carefully inside, do you see this low signal?
Yes, I've got diffuse low signal, and then kind of erosions with that, which would be I would want to look at a T2 star to see if there was
So
blooming
these are
artifact.
T2 stars.
Fine, so there's blooming artifact within that confirms that this is either, but it looks like lobulated, so it could be PVNS rather than hemarthropathy.
Here you are. So this is classical PVNS. You see the patient has presented with effusion without any reason. And then you have seen this hemosiderine. A T2 star is the king sequence here to pick up this hemosiderine, which will be low signal. And please remember that there can be, in your Chapman, there is a differential diagnosis of subarticular lucent bone lesions, very important exam case, and in which PVNS is up there, because you can see what is happening here. So the point is that at times in PVNS, in exam cases, there will be lucent lesions on both sides of the joint. So, so this is PVNS. Okay, let me show you Viva type of a case. Now, pain in the right hip, 73 male. Over to you.
Okay, so I've got an AP pelvis of a 73-year-old male patient with right hip pain. The hip joint is normally in normal alignment. There are no focal lesions of the upper femora. Looking closely at the acetabulum, is intact, as are the pubic rami. There's an impression of I think it's projectional, but there is an impression of lucency over the left pubic rami, but I think that's just projectional because it's going a little bit convoluted. But there is definite asymmetry overlying the sacral alar, and I'm concerned that there's a lytic lesion.
Okay, don't worry about it. Come anteriorly, anything happening at the level of, let's say, the ischial tuberosity, look at the soft tissues also.
There's asymmetry in the soft tissues of the medial compartment of the thigh.
Excellent.
Just looking at the adjacent cortex, there's possible increase. So actually what I was perceiving as lucency on the left could be sclerosis on the right. I'm seeing thickening of the iliopectoneum.
Can you please point out if your mouse function is working?
So
yeah, excellent. So you've picked up something, and with that, where is the soft tissue? The asymmetry. Okay, very good. What will you do next?
I would need to evaluate, preferably with MR, if resources would allow.
So over to you, please.
So T1 axials of the pelvis. I'll just try and get down to the. So there's a hyper intense T1 signal in the left. In the right, so hypo-intense signal in the right acetabulum, where replacing with a large kind of lobulated soft tissue, replacing the where the acetabulum should be, and involving the muscles of the perineum and obturator.
Because of time factor, please keep continuing. You have got more sequences.
Okay. So now this is fluid sensitive, fat suppressed, and The lesion that I was describing is of a heterogeneous density with hyperintense septa and marrow edema in the surrounding bone of the upper femora, but it's completely replacing it. So I've got a grossly destructive lesion in the right acetabulum that's extending into the soft tissues of the adductor compartment of the right medial thigh.
Right, and next sequence, please.
So this will be presumably T1 post-contrast. No.
Still a T1, right?
Yeah, it's just T1. So it's T1 coronal.
Please continue to the next series.
Okay, the lesion's iso-intense to muscle on T1, and this is a post-contrast T1, which demonstrates homogeneous.
This is a
fat-saturated contrast-enhanced study.
So fat-saturated pre-contrast.
Pre-contrast. Okay.
Yeah, pre-contrast. So in MSK imaging, whenever you want to give contrast, you have to do a pre-contrast fat-saturated so that you can compare it, right?
Yeah. So this will be the post-contrast, and in comparison, there is heterogeneous and predominantly peripheral with some septational enhancement.
Okay. What is your conclusion?
There is a large soft tissue mass lesion that is causing gross destruction of the right acetabulum and involves the muscular compartments. It is seemingly centered on the right acetabulum initium. Differentials for a patient of 73 would be a large metastatic deposit. Another differential would be a primary bone malignancy, such as osteosarcoma. Those would be my two main differentials.
Okay. I'll take over, please. Thank you. Now, as I've told you in the beginning, these are favorite for the exam, where they will show you a film in which the finding will be subtle, just like this case. Subtle finding, but a definite finding, and with that is this. Now, there is on a T1 weighted sequence, there is destruction, and with that there is a huge soft tissue lesion, and it is, of course, the inferior ramus, the ischial tuberosity, the acetabulum, everything is involved. And then the same thing. I've given you too many sequences. Usually they will just give you 2 or 3 sequences, and maybe just axial, or so you have to develop your eyes. So this was a point that classically, whenever you do a contrast, you have to do fat saturated, and for that the pre might be given, and this is a post. So there is a lot of necrosis, etc. So this is a soft tissue sarcoma, which is invading the bone secondarily. Please remember, osteosarcoma is a young age tumor, right? That is a young age tumor. Right. Because of time factor, I think I will go to the next candidate, right?
Thank you.
Thank you. So next candidate 3, are you with us?
Hello.
Yes. Okay. Welcome. So let me give you the mouse control, and you go immediately to the Viva case. Have you? Can you move your mouse? Have you got the control as a trial?
I don't think I'm changing it. I'll click the request button.
Now?
Yeah.
Okay, so just I'll take over. Okay, over to you. Patient, the history is that this is 63-year-old female, pain in the upper back.
Okay, so this is a frontal radiograph. Looks like probably the AP part of a thoracic spine radiograph rather than chest X-ray. Given that there is a history of pain in the back, I'm just looking at the spine to see if I can see any obvious bony destruction or other abnormalities like that. I just mentioned that there appears to be quite a large retrocardiac opacity. I don't know if that's relevant in this case.
It is relevant. It is relevant.
Well, then I should discuss it. There's the appearance of a retrocardiac opacity projected over the lower thoracic spine, which appears to have a level within it, possibly an air fluid level. It's a rounded opacity, which, and I can't see the right paraspinal line very well. It might be disrupting the right paraspinal line, which would place this in the posterior mediastinum.
Right or left?
Well, left and right, really.
Okay. Can you point it out to me what you are saying?
So I'm looking. There's round here,
Mm.
and I think it also comes round into this sort of area, and then there's also this edge here.
Okay, very good. Okay, spine. Anything in the spine?
I'm looking for any vertebral collapse or any absent pedicles. I can't see the left pedicle of, I think that's T10.
Point it out to me.
So here, there should be a pedicle.
Excuse me, I cannot see the mouse. There is a...
Oh, oops, sorry. Can you see my mouse?
No. Oh, now we can. Okay.
Okay.
Go back, please. Go. Yeah, now.
This is the area I'm looking at.
Yes.
So here's a pedicle, here's a pedicle, here's no pedicle.
Excellent. Anything else?
It's a little bit difficult in terms of the penetration, but I just wonder whether there's some lucency here, and then the inferior border of this, where there should be a rib, and I can't see that rib very clearly at all. I think the appearances are of a destructive lesion centered around the left paraspinal area in the lower thoracic spine. It also appears to have rib destruction associated with it. I think the patient should have. Oh, so we've got a.
I have gone to the lateral. Where is it placed on the lateral? The opacity, the mass, whatever.
So again, it's posteriorly placed.
Excellent. What will you like to do next?
So I think the patient needs cross-sectional imaging. A CT would be reasonable. But
I have given you an MR instead of CT. So over to you. You can scroll it.
Okay, I'm just going to scroll.
On this sequence, you will describe your findings to me.
Yeah. So this is a T1 weighted sagittal. There's an abnormality which is essentially ISO intense on T1, and it's found, as we identified on the X-rays, in the posterior mediastinum. It's causing, if anything, splaying of the adjacent ribs rather than necessarily destruction, and it can be traced backwards into the spine. So it's passing. So I think it's either passing through a neural foramen or it's potentially actually arising from this. This is the location.
please
of the pedicle.
continue. Go to the next series, please.
Okay, I'll just scroll through. Yeah, I think that was actually emanating from the pedicle. And what we've got here, this is a T2 weighted sagittal sequence. I'm focusing on that same lesion. The bulk of the lesion is T2 hyperintense with a thick lower intensity wall with some heterogeneity within it. And then again, it seems to emanate specifically from this the pedicle of the adjacent vertebra.
Right. So you have got more series, just go through them.
Yeah. That's an axial T2 weighted sequence, which shows that same lesion. I can add to the previous finding that there appears to be a fluid-fluid level within the lesion, implying some differential contents. I can see the focal rib destruction here. The normal dark sclerotic cortical border is lost.
Yeah, please continue. There are more.
Okay.
So what series is this one? Just stop it, please. Name the series. What sequence?
So the fluid is hyperintense, but not as much as the T2. I wonder whether this is a PD.
Look at the CSF.
And the CSF is still relatively bright. It's not as low signal as you'd expect in a T1. Perhaps it's and the fat is mostly suppressed, so it's probably a stir.
On a stir sequence, the CSF will be very bright.
Yeah.
Okay, next sequence, please. This is with contrast.
So this is a post contrast, and we can see vascular enhancement in various places. And the previous one, therefore, was probably a T1 pre.
Yeah. So how do you explain that high signal within it?
So then what that says is that the internal contents are not just pure fluid. They must be either proteinaceous fluid or mucinous fluid, or potentially, the other causes of T1 intrinsic high signal, so melanin, cholesterol, etc.
Okay, what is your conclusion?
So there's a large paraspinal mass which has a thick peripherally enhancing wall and is causing bony destruction, and then internally contains non-enhancing fluid that is high on T1 weighted imaging. I think, and this is in an elderly or older patient who's presented with pain. I think the lesion looks aggressive, and I think that I would consider diagnoses such as malignancy, potentially metastatic from a primary that causes high T1 signal, such as a melanoma or a potentially a mucinous adenocarcinoma, and this could be.
Okay, thank you. I'll take over because of the time factor. Now,
I suppose the rim enhancement, could also imply abscess formation as a differential.
Okay. So let's go back. And the point is that you picked up very well, pedicle is missing. Now, then you look at this. Now, this is rib, this is rib. Look at this distance. This it has increased. You picked it up actually, that there is a bit of scalloping. whatever is happening, it is a long-standing process. It is not causing bony destruction. One point. Second point is that if I give you this film on a chest X-ray, and you remember posterior mediastinal masses, and up there is neurogenic tumors, and then within neurogenic tumors, there can be so many. Neurogenic tumors, please remember, can have cystic components. Just like in the brain, you can have a cystic acoustic schwannoma, remember that. So they can have, radiologically speaking, many types of appearances. So these things tell you, just this pedicle, you cannot comment, but once you see this is long-standing. And then here, you picked up very well that it is going into the neural foramen, and on the axial also, that was confirmed. So another point here will be that on, T1 pre-contrast fat saturated sequence, the physics is slightly different and everything becomes slightly higher signal than normal. And at times you will make a fool out of yourself, particularly in the spine, where it will appear very high signal. And actually that is normal. It's normal physics. So develop your eyes on a T1 fat saturated pre-contrast. And this was given just so that you can compare it. Of course, in the real world, on a DICOM viewer, this will be, you can, the next sequence will be with it, so you will not be handicapped. But this was high signal, means there is the simplest thing is that it's hemorrhagic component. Of course, it can be proteinaceous, but it's hemorrhagic component. Just like, think like an endometrioma, and now you can see that the periphery is enhancing. So point to remember is that neurogenic tumors can have cystic component. So this was a neurogenic tumor. But again, the emphasis which if you see all of the cases which I have shown you, subtle finding and then characterization of MR. So that is what, exam cases are about. Okay, I will again go into the spot diagnosis, please. Can you see my screen?
Yeah. So I can see that there's a quite large lytic lesion in the metaphysis of a skeletally immature patient's tibia. It seems to have a fracture, or at least some cortical irregularity at the medial aspect. I think this, I mean, it's not projecting very well for me, but I think it could be a simple bone cyst with a pathological fracture for it.
Right, and I can appreciate that it's not projecting very well. The resolution is not very good. What do you call this thing?
So in that case, that would be a fallen fragment.
Right. Now, simple bone cyst. What else can it be?
So there, I mean, then there's other differentials of lucent bone lesions. It could be not simple, so it could be an aneurysmal bone cyst, but there's no real expansion. Something I'd always want to exclude in a pediatric patient with a metaphyseal lucency is a Brody's abscess. It doesn't have a hugely sclerotic border, but in that case, the more sclerotic part in the center could represent a sequestrum. I'd also be thinking of an eosinophilic granuloma. I think that there's a possibility. I think the lower inferior border of the lesion on the AP projection, certainly for me, doesn't look very distinct.
No, it is. So you are a bit handicapped because of the resolution, so don't worry about it. I've got an MR of this patient. What do you think?
Okay, so on fluid-sensitive MRI sequences, sagittal and axial, what we can see is the lesion has multiple internal locules with fluid levels. I think this is typical for an aneurysmal bone cyst.
Excellent. Okay, let's go back to the basics. Now, your differential was fine, but the point is that how do you differentiate between, a classical textbook aneurysmal bone cyst which has expanded like anything? Don't think that all aneurysmal bone cysts, when you image them, will be as aneurysmal. So, one of the key things to differentiate between an ABC and simple bone cyst is that is it central in the medullary cavity versus eccentric. So classical location of aneurysmal bone cyst is, you remember that diagram in Chapman, where simple bone cyst is central and aneurysmal bone cyst is eccentric, and this is slightly eccentric. And classical location of aneurysmal bone cyst is metaphyseal, and simple bone cyst classical location is metadiaphyseal, here central. And then there is a concept of migration of cyst, where it migrates towards the diaphysis as the child grows. So that also goes in favor of. But in the exam, nobody will mind if you say both of these things. But having said that, retrospectively speaking, these points are valid, as I have pointed out. Please remember, fallen fragment sign is not a pathognomic sign for simple bone cyst, and it can be seen in other stigmata. And then fluid levels. If you see more than 75% fluid levels, you are quite confident that it is an aneurysmal bone cyst. Yes, please.
This is a lateral radiograph of the right calcaneum of a skeletally mature patient. There is a well-defined lucent lesion in the mid to anterior part of the calcaneum, which is, as I mentioned, predominantly lucent, but there are some speckles of calcification within it. They make me consider that might be some matrix calcification, in which case I think this lesion is consistent with a enchondroma. A differential would be a calcaneal lipoma, intraosseous lipoma, which, if chronic, could potentially have a bit of calcification within it. I think the lesion has benign features, and there's no periosteal reaction or soft tissue.
What will you do next?
I'd be interpreting the radiograph in the light of why it was taken. If this is an incidental finding, I don't think it requires any further action. But in any case, I'd be comparing to any previous imaging to see if there's serial change in the lesion.
So there is no previous X-ray.
Okay. I think that radiographically this lesion is benign, and I don't see any evidence of a fracture or any other complication associated with it. If there was any clinical concern about the nature of the lesion, a focused MRI scan would be a reasonable course of action.
MR?
So what we've got is sagittally oriented, fluid sensitive, I think a stir in the middle, and a fat sensitive sequence. Looks like a T1 weighted or sequence. The lesion is inherently high signal on the fat sensitive sequence, and saturates out on the stir. So I think this is a lipoma.
Right. Okay, let's go back to the basics. You have picked up a lesion there, and your differential was lipoma versus enchondroma. By the way, whatever you were seeing this calcification, there is a bit of central, maybe here calcification, but a bit of trabeculae are also projecting. It's not classical chondroid matrix. This is also not a classical site of enchondroma. Calcaneal lytic lesion is a very important exam case. It has come in the exam many a times, and there are specific things which you have to remember. And one of them is simple bone cyst. It all depends on the age group. So in here you are a bit handicapped, but you feel that this is not a child. So chondroblastoma can occur there, and in a slightly advanced age group, not advanced, middle age, it can be a giant cell tumor. It can be a lipoma, as you have pointed out. It can be what we call, hemophilic pseudotumor, calcaneal, that is there. Known site, and it has come in the exam quite a few times. Brown tumor of hyperpara, this is another one. So there is quite a favorite location for a specific differential, as I have told you. And some of the things might not be very specific. So nobody in this era is stopping you to ask for an MR. Don't be shy of asking an MR because you are unable to characterize this. In the real world, there are some lesions. So I'm coming out of this case and giving you the general concept that what we call don't touch me lesions. When you are in a black and white world, in a plain film, for example, there is a fibrous dysplasia, just call it a fibrous dysplasia, and there will be no role of further imaging. A non-ossifying fibromas, call it a non-ossifying fibroma, or a fibrous cortical defect, or a simple bone cyst if you are. But here you are not very sure, so ask for an MR. Yes, please. This might be the last case of the day. We have already gone beyond about 20 minutes. So this will be the last case for you.
So I'm presented with AP and lateral radiographs of the right humerus of a 62-year-old female. Their bone looks broadly quite normal, but there's an obvious abnormality of the soft tissues of the anterior compartment of the arm, where there is some fluffy, slightly amorphous calcification, quite irregularly distributed, which implies that I think there's a soft tissue lump there within the arm. I'm trying to see whether this is scalloping the adjacent humeral cortex, or indeed potentially arising from the bone. I can't see any convincing evidence that it is, but nevertheless, there's clearly a quite large soft tissue lesion, probably within the muscle layers. I'm told that it's quite long-standing. If it's been previously investigated, I think it would be a good first step to review any prior images to see whether it's got larger. Otherwise, further investigation is necessary because the calcification might only represent part of the lesion.
And what do you think can it be? Do you see this? What do you think? This density?
So it looks like, if we take it that the entirety of the lesion spans from this curvilinear area of swelling all the way around to this sort of area, that some of it is projecting as soft tissue density, some of it is calcified, but some of it might be fat density.
Right. So what are you going to do next?
So then I think, especially if this is growing or painful, we've got to be concerned for potentially a liposarcoma. I think an MRI would be appropriate.
So T1?
Yeah.
This, and then pre-contrast and post-contrast sequences are here.
Okay, so just reviewing those sequences, there's an ovoid lesion located primarily posteromedial to the humerus. This contains quite heterogeneous tissue of various signals. A large part of it is hyperintense on the T1 and saturates out on the fat-saturated sequences, consistent with macroscopic fat. But there's also a T1 iso intense soft tissue component that appears to be enhancing after the administration of contrast. And and some low signal foci, which probably represent the calcification. The overall appearances are suspicious for a soft tissue neoplasm, and a liposarcoma has to be considered a possibility. Therefore, I think the patient should be discussed at the regional sarcoma MDT and planned for a biopsy made with their input to ensure a safe tract.
Right. Okay. So you see, liposarcoma is an exam case, and both type, the lesions which are black and white, like this case, this is a definite liposarcoma. And second are lesions which are, in the gray category. And how will you deal? Both have come in the exam. So this is a slam dunk, absolute, imaging wise, this is a liposarcoma. It gives you low density, then calcification here. And so it was long standing, means initially it must be a lipoma, and then it has converted into a liposarcoma. And classical, this is the fat component, and then this is enhancing component on. So you did well where you referred it to the sarcoma unit, and they should do the biopsy. You should not do the biopsy, everything. So that is all.